Hello, guys. My name is Catherine Lester, and today I'm going to talk to you about the neuroscience of bipolar disorder. The purpose of this presentation is to help us understand the neurobiology of bipolar disorder, one, by determining if subcortical volumes of certain brain structures differ in those with bipolar disorder, and by identifying regions of the default mode network, or the DMN, that are affected in bipolar disorder. Bipolar disorder, also known as manic depressive disorder, is a severe chronic mental health disorder broadly characterized by mood swings of alternating periods of mania or hypomania and major depression. It is a broad spectrum of affective disorders that includes bipolar 1, bipolar 2 disorder, and affects around 1% of the global population. Mania is defined as periods of elevated energy and mood with lowered inhibition. Mania can severely affect the life of sufferers and may include delusional thinking and periods of psychosis. Hypomania is a less severe form of mania that does not usually require hospital admission. Mania lasts for a week or longer, while hypomania typically runs its course after 4 days. Bipolar depression is an extended period of decreased mood and motivation and may also include catatonia, psychosis, and thoughts of self harm and suicide. People suffering with bipolar disorder can be more than 20 times more likely to die or attempt to die by suicide. According to the Diagnostic and Statistic Manual of Mental Disorders, the fifth edition, or the DSM 5, bipolar 1 disorder is characterized by a period of mania and may have depressive episodes, although these are not required. The requirements for the diagnosis of bipolar 2 disorder are at least one period of hypomania and a period of major depression. It currently relies on long-term monitoring to reach an accurate diagnosis, since there is currently no diagnostic test approved for diagnosis. According to the Mayo Clinic, some other symptoms of bipolar disorder include irritability, restlessness, sleeplessness, engaging in risky behavior, distractibility, grandiose thoughts, racing thoughts, loss of pleasure in most activities, fatigue, low energy, sleeping too much, difficulty concentrating and making decisions, physical agitation, and suicidal thoughts. Previous studies have shown some indication for abnormal pathophysiology with this spectrum of disorders. For instance, several alleles associated with schizophrenia have also been implicated via genome studies in bipolar disorder when dysregulated. Studies have also repeatedly shown abnormal spontaneous local brain activity during fMRIs. Dysregulation of the dopaminergic system is also thought to affect bipolar patients, but the specific dysfunction has not been identified as of 2016. In postmortem brain studies, dendritic spine loss has been found in the brain tissue of those with bipolar disorder, and several other contributing factors being studied currently include inflammation of neural tissue, oxidative stress, patterns of DNA and histone methylation, and mitochondrial dysfunction. The Enhancing Neuroimaging Genetics through Meta-Analysis Consortium's Bipolar Working Group's work has found that patients with bipolar disorder also seem to have lower subcortical volumes in both their hippocampus and thalamus. The research looks to replicate these findings as well as to expand into other brain structures. So today we're going to discuss some basic neuroscience principles. I will be discussing several brain structures, so I'd like to give an overview of them. The thalamus is a sensory relay station. The hippocampus is involved in memory. The caudate is involved in memory and emotion. The putamen functions in behavior reward and movement. The globus pallidus is involved in cognitive function and motivation. The amygdala is important for regulating emotions, especially negative ones like anxiety. And the nucleus accumbens, right there in yellow, is like a pleasure center, which is involved in motivation. The default mode network includes the medial prefrontal cortex, the posterior cingulate cortex, the precuneus, the inferior temporal cortex, and the parahippocampal cortex. This region of the brain is active when you are awake, but not directed in a goal-driven task such as daydreaming, memory and emotional processing, recollection, and self-referential thinking. So to go over some of those functions, the precuneus of the DMN, the precuneus is the posterior medial parietal lobe and is responsible for emotional regulation. It is especially sensitive to negative emotions. The medial prefrontal cortex is very well studied and functions in social cognition, or the ability to integrate and apply social information into how we perceive the world, memory, decision making, and emotional experience. So the first paper we're going to go over are differences in subcortical brain volumes among patients with schizophrenia and bipolar disorder and healthy controls. So for patient selection, for the experiment, researchers selected 413 participants of Japanese descent because they were located in Japan. Of these, 157 were diagnosed with schizophrenia, 51 with bipolar disorder, and 205 healthy controls. The schizophrenia patients were split between 62 males and 95 females with a mean age of 42.8 years. The bipolar patients were split with 27 males and 24 females with a mean average of 46.5. Of these patients, 16 were diagnosed with bipolar 1 and 35 with bipolar 2. The control patients were split between 133 males and 72 females with a mean age of 35 years. Each patient and the control were diagnosed by two psychiatrists based on criteria from the DSM-5. Controls were excluded if they'd had previous psychiatric care or had a family history of first or second degree relatives with a psychiatric disorder. Participants were also excluded if they had any condition or medication that could affect the central nervous system. Before inclusion into the study, all participants were screened using MRI to exclude any person with abnormalities like DFARCs, any abnormalities like DFARCs or hemorrhages. Patients were also evaluated for IQ and handedness, as well as clinical symptoms, depression, and mania. Researchers used this instrument here, the Siemens 3T magnetron trio MRI machine, to take T1 weighted images of 192 slices of the sagittal plane of the brain, so moving front to back. A benefit of using T1 weighted images is that it provides a good contrast between white and gray matter. You will see a T1 weighted image later. Images that contained artifacts or depictions of motion were excluded from the study. Images were processed using Harvard's FreeSurfer program version 6.0 with the default automated reconstruction procedure to obtain the subcortical volume of the 7 brain structures: the thalamus, the caudate, the putamen, the globus, the pallidus, the hippocampus, the amygdala, and the nucleus accumbens, along with their intracranial volume. Images were evaluated by trained researchers, but images from the program were not manually reclassified. So if the program classified an image or volume as one measurement, researchers would not go back and reclassify that image. FreeSurfer version 6.0 is the newest version of this program and offers the most accurate measurements of subcortical volumes when compared to earlier models. It is also much faster and cuts down on analysis time, which you could see would be very useful with as many slices as they had to look at. In order to determine whether differences in the sizes of the 7 studied brain structures were actually due to psychiatric conditions, researchers corrected results for 3 covariates: age, sex, and intracranial volume. So someone with a larger intracranial volume might already have a larger amygdala, so values were corrected to standardize these results so that it was as if everyone were the same age and gender who all had the same ICV. That way they could see true differences in the sizes of these structures. They did this by plotting the results as a linear regression and taking the unstandardized residuals. Residuals are the differences between the actual results and the expected results and can help determine if a statistical model is a good fit for the data being analyzed. So residuals, when you plot a straight line, the residuals will be points above and below the line, how far those points are from the actual line. For ease of understanding, the residuals were added back to the intercept value before statistical analysis. To determine how much a Participants' subcortical volume differed from others. Researchers used Cohen's d statistical analysis, which tells you how big a difference is, not if there is a difference. The higher the number, the more likely the result is to be significantly different. The Pearson R test was used to determine if the left and right sides of the brain correlated with each other to determine if further correction was needed, and researchers determined that it was not needed. To reduce the risk of making a type 1 statistical errors, researchers used the Bonferrari correction, in which they divided the normally significant p-value of 0.05, which is what we use most commonly in science, and they divided this by 7 to get a p-value of less than 7.14 times 10 to the negative third. So in order to be considered significant, Cohen's d values had to be less than this value in order for the result to not be mere chance. And that is an incredibly tiny significance value. This is advantageous because it greatly reduces the risk of a result being considered significant when they're just merely by chance. So for the results, this is the results of the first paper. Bipolar patients showed stronger connections between the hippocampus and the amygdala volumes. And you'll see the bipolar and the control in this middle line in B. While several structures, the left thalamus and bilateral hippocampi and the left nucleus accumbens initially appeared to have significant differences, after the Bonferrari correction, only the differences in the bilateral hippocampi remain significantly different. And you can see that the BB group has a lower subcortical volume for their left hippocampus than the control group, and the mean difference for the schizophrenia group. As you can see, the amygdala did not differ significantly between the three groups. So researchers showed that patients with bipolar disorder had lower subcortical volumes of their bilateral hippocampi than control or from schizophrenic patients. Now we're going to go over the second paper, which is the disrupted default mode network connectivity in bipolar disorder, a resting state fMRI study. So for this paper, there was a total of 150 participants selected for the study. There were 85 healthy controls and 65 bipolar patients. Patients were matched for covariates like age and gender. Participants were excluded from the study if they had excessive head motion during testing, which ultimately excluded 13 participants. Bipolar patients were screened for mania and hypomania using the Young Mania Rating Scale, and for depression via the Hamilton Depression Rating Scale. Participants were not selected if they were experiencing hypomania or mania, since bipolar patients spend less than 20% of their time in one of these states, and researchers were attempting to assess the brain in a resting state, not in these elevated manic states. Researchers did not differentiate between bipolar 1 and bipolar 2 disorder, but categorized them all together. Using the Siemens 10 Trio 3T scanner to acquire functional images and T1 images, which you can see up here. And as we discussed earlier, it gives great contrast between the white and the gray matter. Patients were instructed to relax and avoid movement during the test. Excessive head motion was determined using the frame-wise displacement method, which measures how far the head is moved from the previous frame. And images that showed head movement during the images of less than 2 standard deviations from the rest of the participants were used for analysis via the data processing and analysis for brain imaging program version 3.1. Abnormal brain activity was determined using 3 indices, and I will go over all 3. There is the rational amplitude of low frequency fluctuations, or the FALF, and that measures fluctuations in blood oxygen usage. The REHO right here is the regional homogeny, and it measures the functional connectivity between regions. The DC is the degree centrality, and it is the summed functional connectivity of each region in the brain with other regions, so how that region talks to other regions. Using these methods, researchers were able to search for brain anomalies in the entire region of the brain in an unbiased manner. Data was then converted into Z-score maps to show areas of significant increase or decreased brain activity. Statistically, groups were compared via the chi-square test to determine if groups were equal in terms of the mix of categorical variables. For brain activity scores and age, results were analyzed using the Shapiro-Wilk test to determine if the results could be approximated to a normal curve. Based on whether results fit the standard curve, researchers then used a two-sample t-test or a Mann-Whitney U test to compare the brain activity averages between the bipolar patients and healthy controls. Statistical analysis was performed using the SPSS 20.0, while brain mapping images were created using the SPM 12 program. After analyzing the variables, it should come as a surprise to no one that the group of bipolar patients were more depressed than the controls, with their HAM-D scores were significantly higher for bipolar patients. And this image displays the results for the three indices measured in the study. So here you can see the FALF ratio, here you can see the degree centrality ratio, and here you can see the regional, the REHO indices. The portions lit up in each image shows the region of the precuneus in the bipolar brain. From each whisker plot, you can see that the size of the precuneus was slightly smaller or significantly smaller than those found in healthy controls. So you can see that the volume of the precuneus in all three images are significantly less than the whisker plot that shows the control patients. Interestingly, researchers did not find any correlation between the precuneus's size and the reported depression from bipolar patients. This is an image of the precuneus containing 47 voxels. Voxels are like representations of segments of the brain in 3D cubes that act like pixels. And the connectivity activity to other areas in the left precuneus, the medial prefrontal cortex, and the left putamen. As you can see from the whisker plots, there was decreased resting state functional connectivity of the precuneus with other areas within the left precuneus and the medial prefrontal cortex, while there is increased connectivity with the left putamen, which is shown down here as a negative bar. Let's see. Okay. Through FALF, we can see that there is less local oxygen usage fluctuation in the precuneus, and through the REHO, we see decreased ability of the precuneus to synchronize activity. Through the DC, we see reduced connection of the precuneus to other regions. Patients with subcortical volumes, patients with bipolar disorder had lower subcortical volumes of their bilateral hippocampi than control or schizophrenic patients. They also displayed altered resting state functional connectivity in the DMN. Since the hippocampus is responsible for memory, it makes sense that these patients would experience deficits in their working memories and attention. The three indices show less metabolic activity in the region of the precuneus because these indices can be considered biomarkers for activities. Since the precuneus is involved in emotional regulation, decreased activity and lack of synchronicity within it and from it to other areas may explain why patients with bipolar disorder have a very difficult time understanding and responding to emotional content. Decreased activity in the precuneus might also be related to increased rumination in depressed bipolar patients, in which patients focus on negative thoughts constantly without problem-solving activity. Therefore, it is interesting that researchers did not find a correlation in the activity within the precuneus and the depression scores of the bipolar patients. Researchers found decreased connectivity between the left precuneus and the medial prefrontal cortex. The precuneus is associated also with self-centered mental imagery strategies and memory retrieval, while the medial prefrontal cortex is involved in memory, emotional regulation, and decision making. So it seems that the abnormal resting state functional connectivity between the anterior and posterior portions of the DMN could be involved in the defects of attention and working memory in patients with bipolar disorder. The precuneus voxels show increased connectivity with the left putamen of the salience network. The salience network is involved in extroversive attention orientation, so increased connectivity between the two can explain why bipolar patients struggle with maintaining attention and a reduction of introspective thinking when compared to rumination. Decreased connectivity between the left precuneus and the medial prefrontal cortex, and increased connectivity with the left putamen, meaning there is diminished spontaneous activity in the left precuneus and the DMN overall, with increased activity with the left putamen and insula, just to sum it up. Since the DMN is thought to be an area involved in self-consciousness, such as feelings about oneself and autobiographical information, it makes sense that decreased activity in this area is connected to depression and accompanying negative feelings about oneself during a bipolar episode. So the first study was a replication study, but the second study was a novel one. However, both could have used more participants, especially the first one, which had a very low number of bipolar patients. The small sample size could also affect how accurate the results are. In both studies, bipolar 1 and bipolar 2 patients were grouped together regardless of where they fell on the spectrum. I think a better understanding of bipolar disorder might come from these studies if the bipolar patients were separated based on diagnosis and then imaged. A further direction for this line of experimentation would be to examine the brains of people experiencing an active episode of mania or hypomania to determine how the brain switches between the two modes. And these are my references. Thank you very much, guys.